We are live. Hello, everybody. For those of you who don't know, my name is Dr. John Kennedy. I'm the Medical Director of Therapy Fertility, and it is Friday. It's 2:30, and we are doing another Instagram Live. We do a lot of these, and generally we answer questions that you guys have sent in. I pushed for this one to be done. I said, listen, I want to do an Instagram Live, which normally I don't ask to do at all. I have to be dragged into these things. Because I want to talk a little bit about progesterone. And then Renee, as she always does, posted a call to action to get some questions, and by God, have you responded. So I think that speaks. There is 7 screenshots of questions, about 8 questions per screenshot. So there's a lot. And that speaks to the massive amount of interest that there is in this area. And it also, unfortunately, speaks to the massive amount of confusion that there is in this area. So what I'm going to try to do today, I'm going to spend a little bit of time. I'm going to talk about progesterone. I'm going to talk about what it is. I'm going to talk about when we use it. I'm going to talk about why we use it. I'm going to talk about where are its upsides and where are its downsides. And then I'm going to try to speak a little bit to the confusion that's out there over why everybody does different things and is there value in that or not, and specifically try to fold in, hey, why do we do things the way we're doing them, and should we be doing things differently? Which is always a question we would ask ourselves. So let's get into it. What is progesterone? Progesterone is a hormone that's produced by the ovary, specifically by the corpus luteum in the ovary. What's the corpus luteum? Well, in a natural cycle, what will happen is you'll get a follicle that develops in your ovary. That will develop over the first 2 weeks of your cycle. That follicle will then release an egg. That's your shot at pregnancy that month. That follicle then turns into a corpus luteum. It kind of looks a little bit grayish on ultrasound. It doesn't look as clear as it otherwise was. That corpus luteum produces progesterone. Progesterone, in the context of the back half of your cycle, makes the lining of the womb ready for implantation and helps support a pregnancy in its early development. So that's why progesterone is really, really important, because it makes the womb ready. If a fertilized egg, an embryo, doesn't make its way into the womb and implant about 2 weeks after you, about 8 or 9 days after you ovulate, then that corpus luteum degenerates, your progesterone drops, and you get a period. That's your natural cycle. You build up the lining, you release an egg, the corpus luteum produces progesterone, no pregnancy happens, the corpus luteum involutes, the lining releases, go back to start. So one of the things that people often come in with is, I've checked my progesterone. My GP checked my progesterone. He checked it on day 21. It's low, it's normal, it's high. What is that? Well, we anticipate that after you release the egg, that follicle turns into corpus luteum, that starts producing progesterone. So if you have a 28-day cycle and you check somebody's progesterone levels on day 21, that's a week after they've ovulated, they should have progesterone in their system at that stage. If their progesterone is low, that probably means they didn't ovulate, okay? One of the questions that we get asked is, what if the back half of my cycle is short, if I bleed early, if I have what's called a luteal phase deficiency? Can that have an impact on my ability to get pregnant? So the theory being, I've released an egg, I've given some progesterone, I should be getting my own progesterone, but it's not enough, the lining's not maintaining, so even if I have a fertilized embryo, it's not going to implant because I don't have enough progesterone in my system. And that's why a lot of centres for timed intercourse, places like that, would give progesterone at the back end. That is controversial, and the evidence of benefit of that is not zero, but it's not strong either. I think an awful lot of people, and God knows I've been guilty of this as well, have given progesterone to be doing something. And I think you're going to see this feature recur throughout this conversation today, is that we do it to be doing something as opposed to because we think there's a tangible benefit to it. Chances are, if the follicle didn't contain a viable egg, then the corpus luteum isn't going to be as good, so it's not going to work out in any case. It's not because there's not enough progesterone, there's a luteal phase deficiency, it's because the egg wasn't of sufficient quality that month in the first instance. But as I said, that is controversial. So, why do we give progesterone in fertility treatment? Well, There's two kinds of fertility treatment we do. There's IUI or IVF with fresh transfers, and there's frozen embryo transfers. With IVF or IUI, you're stimulating the ovaries to produce loads of eggs, which in turn, after you do an egg collection, will produce loads of corpus luteums. So there's buckets of progesterone in the system. In fact, we've got to check it to make sure it doesn't go too high too early and impact and make the lining not ready at the time the embryo is going back into it. So under those circumstances, there is no evidence that you actually need progesterone support in either fresh transfer IVF cycles or IUI cycles. Hey, guess what? We all give progesterone anyway, because it's easier for us to give progesterone in the back half of the cycle because we don't think, I'll talk about this again, that it does any harm. So we tend to give it. We tend to give it and we tend to just support just in case, to be sure, belt and braces. But where you really need progesterone is in a frozen embryo transfer cycle. This is where you've done a cycle of IVF, you've frozen embryos, and now you're giving estrogen to build up the lining of the womb, and then you're giving progesterone to make the womb ready, and then you're doing an embryo transfer. Now, you really need to give progesterone in that situation because there's no corpus luteum. There's nothing there that's producing the progesterone, so it has to come from external sources. So that really is the question: is how much progesterone should you give, and when should you stop it? So what we do here is we give progesterone, and we keep the progesterone going in all our cycles, because if we do the same thing for everybody, it's less likely to cause mistakes to happen, and it's more consistent, and it's easier for people to understand, and it's easier for us to administer as well. So we give progesterone, and we give it until the first scan, the first obstetric scan. If that scan is good and reassuring and everything looks well, then we generally discontinue it at that point. At that point, the pregnancy is producing the progesterone that it needs to self-sustain. In fact, the pregnancy has been producing that progesterone for the last 4 or 5 weeks. You definitely need progesterone for the first 2 weeks following implantation in a frozen embryo transfer. After 2 weeks, it's controversial whether or not you need it. After 6 or 7 weeks, it's really controversial, and the evidence of benefit drops to almost zero. The latest guidelines on this, the latest guidance on this suggests that you should, in a frozen embryo transfer or an IVF cycle, you should discontinue progesterone at 7 or 8 weeks. The only circumstances under which they recommend continuing progesterone beyond that is if you have a history of pregnancy loss and you have bleeding in that pregnancy. And then when you dive into the evidence of that, even there, it's very, very difficult to show there's any actual statistical benefit in keeping the progesterone going. But that's not a hill I'm willing to die on. I think it's perfectly reasonable under those circumstances to continue progesterone. But of course, that creates its own controversy, doesn't it? Because now I've got somebody in front of me. I've done a frozen embryo transfer. She has a history of no pregnancy loss, but she has bleeding. So I'm going to tell that woman, well, I'm not going to continue the progesterone because you haven't had a miscarriage. Now, if you had a miscarriage, I'll do it the next time. That seems to me to be a little bit paternalistic, a little bit draconian. So in those circumstances, you would certainly think about progressing it, with the caveat that it is almost certainly not going to make any difference at all. And that's the heavy caveat on this. So there are circumstances under which we continue beyond it. Is it safe? We think so. There is probably a value at which you are giving too much progesterone and maybe it'll do some harm. There hasn't been enough research done in this area for me to know definitively one way or another. Most of the data would seem to suggest that really giving progesterone is reasonable. Giving too little progesterone can be a problem, so you need to make sure that you give enough progesterone. On that, the progesterone we tend to use here for the vast majority of our major cycles is a subcutaneous form of progesterone. So it's injections, and we give them twice a day. Now, in the past, I generally prescribed vaginal progesterones, cyclogest or utrogestin or crinone or something like that. I worked in this gig for years, and the feedback I got from patients was that the side effects are the local irritation, the local vaginal irritation you got from vaginal progesterone was horrific and really, really uncomfortable, and it was just awful. So I said, right, in the last number of years, this subcutaneous progesterone came out on the market. I said, great, look, this seems to have the same efficacy as intramuscular, which we think is probably the best way to get progesterone. This seems to be as good as that. And these women are already on injections, so maybe they're a bit used to them, so we're going to try this. So we're going to use subcutaneous progesterone as a standard here instead of vaginal progesterone. And I'll be quite honest with you, the feedback I've got over the last year is that the injections are really sore and it sucks. So look, the takeaway from that for me is that progesterone is awful. It's an awful bloody medication. Its side effects are awful. It causes you to feel early pregnancy symptoms. It causes abdominal bloating. It causes breast tenderness. It causes joint pain. It causes nausea. It mimics the symptoms of early pregnancy very effectively, which is a really dirty trick to play on somebody who thinks they might be in early pregnancy. So ultimately, the data is very clear. We don't really care if you take the progesterone vaginally or subcutaneously or intramuscularly or orally, except that orally causes awful side effects and intramuscular is just about one of the worst things you can do to a person. The side effects are horrendous and you get sterile abscesses and it's all just terrible. So as a general rule, we give subcutaneous progesterone. Now, are we giving enough? And we didn't really want to get into are we giving enough to people or do we have to judge it on a case-by-case basis, especially when we knew that we could go over the top on this a little bit and give way more than is necessary without doing any harm. So, subcutaneous progesterone, Prolutex or Lubion, is a once-a-day medication. That's how it was designed. It was designed to be given once a day, every day. There was a study, it's not massively convincing, it's a bit small, but it showed that maybe the bioavailability of the progesterone drops in the 3 or 4 hours before the dose. So maybe there's a little bit of a drop. Very hard, no real clear evidence that correlates with poorer outcomes or anything like that, but it's there. So what we do is we give it twice a day. We're giving Prolutex twice a day at 12-hourly intervals, making sure that the bioavailable progesterone to support the pregnancy is always above where it needs to be. By doing that as a standard, we are taking off the table the concern that you're not getting enough progesterone. You're definitely getting enough progesterone. In fact, you're getting far more progesterone than you need. You need, maybe at once a day, you're getting 100% more than you need. All right, because it was already designed as a medication that would, give loads of progesterone. Equally, if you're taking vaginal progesterone, you're probably taking it 3 times a day. You really probably only need to be taking it twice a day or possibly once a day. Okay, so the question, do I need more progesterone, is never a relevant question for me because we've started off at such a high level. But of course, we still get asked. So, without further ado, I'm going to get into some of the questions. Some of them I'll have addressed through what I've already said, but there'll be other things. Why do clinics not test progesterone in 2-week wait? That's why. Because we know we're giving enough progesterone that its bioavailability is there and thereabouts. The other reason not to test, especially if you're giving vaginal progesterone, and this is another thing you need to be aware of, is that the serum concentration of progesterone that you get from a blood test won't necessarily reflect what's happening in the uterus because you're giving the progesterone that's getting locally absorbed. So that's something to think about. Is Crinone the same as Cyclogest, just a different brand? They're both vaginal progesterones. Cyclogest is a little pearl thing. Crinone is a gel. I got no skin in the game. People seem to prefer Cyclogest to Crinone as a general rule. Crinone's a bit nasty. And there's a bulking agent that comes with it and that comes away. So if you give people Crinone, you have to prepare to tell them, listen, this stuff is going to come out, but it's not the Crinone. You're getting the progesterone. It's just the bulking agent. But everybody freaks out about it because they think they're not getting their medication. Do I need to be taking it if I'm 4 weeks pregnant naturally? Almost certainly not. Almost certainly not. You don't. See what I've said for details. You're producing your own, either the corpus luteum is doing it a bit or the pregnancy is doing it a bit at this point, and you probably don't need it. But the next question here is, can it help prevent recurrent miscarriage? And everybody who has a history of recurrent miscarriage, who goes to a recurrent miscarriage clinic, will be put on progesterone as an absolute standard. The evidence that it prevents recurrent miscarriage is really, really thin. It really is. I'm not saying it's zero, and I'm not saying it's inappropriate to give progesterone to people who've been through absolute hell. I'm saying that if the miscarriages are down to the quality of the eggs and the embryos, specifically the embryos, as they are like 80-90% of the time, then giving extra progesterone in that situation is not going to help. Why is it so important to monitor the progesterone levels after embryo transfer? It's not. That's what I'm saying. What you might consider doing is monitoring progesterone levels in a pregnancy where you aren't giving progesterone. And that's where it gets really interesting, because if you see somebody and they're in early pregnancy and you do a blood test and their progesterone is lower than it should be, say knocking around, you want it to be at around 26, 28 nanomoles, and maybe it's less than that, then can you make the statement, well, this person's progesterone is low, they're not getting enough support, I need to add in progesterone and then the pregnancy will continue. Makes perfectly logical sense, but unfortunately that's not how it goes. The progesterone is low because the pregnancy is not performing the way it should. So by adding in progesterone, you aren't going to turn this into a live birth. We all do it anyway, but it's just that's not how it goes. You might delay the bleed a little bit, because you're supplementing it, you're stopping the body's natural mechanism from dropping the progesterone and unfortunately having an early pregnancy loss. So you might delay the inevitable a little bit, but unfortunately you're not going to fix the problem. So finding out that somebody's progesterone is low is never a good sign, but unfortunately giving progesterone in that situation isn't the solution, although we all tend to do it. Are pessaries superior to subcut injections, or what is the rationale to use one over the other? Okay, so we've dealt with that. They're the same. It's just whichever one suits you better, we can chop and change. Can progesterone supplementation help to get pregnant if luteal phase is short? Maybe. Small maybe with asterisks beside it, but yeah, maybe. What should progesterone be to confirm ovulation? Depends who you talk to. Some people would say over 20. Some people would like it to be over 30 or 35. An old boss of mine used to say 20, but everybody else I spoke to said over 30. So make of that what you will. Why some clinics and hospitals say 12 weeks? Why do you stop giving it at 7 weeks when other clinics do until 12 weeks? So all the evidence on this is really, really clear. You can stop, unless you've got the very specific circumstances I alluded to, bleeding in that pregnancy and a history of miscarriage. It is safe, reasonable and medically correct to stop the progesterone at 7 or 8 weeks. So why do people continue doing it? Well, it's the same reason I'm doing this Instagram live. I'm trying to educate, but I'm also trying to respond. We have had criticism on this. I'm trying to respond to that saying, look, other people are giving it, so why don't you? They're giving it because why wouldn't they? Okay, why wouldn't you give it? Just give it. Just give it. Why don't you give it? Now, my problem with that is that's the wrong question. The question is why wouldn't we give it? The question is why would we give it? Why would we give people injections or vaginal progesterones that cause side effects, that don't diminish pregnancy rates, but cause problems, that cause anxiety, instead of letting these people get on with their lives? We need a reason to do something, rather than we need a reason not to do something. Now, I feel like an army of one, this organization here, because other people are giving it longer, and who knows, maybe we'll eventually go that way. But make no mistake, this field has become incredibly woolly, and most clinics are giving progesterone for longer. They certainly don't have any wealth of evidence that says they should. They're doing it because then they don't have to deal with the conversation of why aren't you giving me the progesterone for longer. That's at the core of this. You're giving it just to stop the conversation, because the conversation becomes exhausting. And it also becomes a bit confrontational at times. You go, well, I want it. I want it for my own peace of mind. I want you to prescribe me medication, which we all agree won't make any difference to me, but I want it for my peace of mind. That's not great. That's not a great look. It's not a great look for anybody. It's certainly not a great look for clinicians and healthcare professionals who are trying to do their best for people. Of course we're all on the same page. Of course we all want the same outcome. I don't want to be seen to be withholding, miscarriage, you come back for another cycle. That's insanity. So you're giving it because it's just easier. Anything for a quiet life. That's the logic. Day 21, 28 nanomoles. Okay, presumably that. 28 nanomoles progesterone. Okay. Unexplained infertility by 4 OI, TSI by 1 miscarriage. Progesterone support. I mean, you're ovulating. You're ovulating with those numbers. You're getting pregnant. 4 ovulation inductions, so you've got about 15 to 20% positive pregnancy test rate. You've had 1 out of 4. That fits. You can certainly take progesterone support, but there's no evidence of benefit in that. Now, I don't know much about the rest of your history, age, and all the rest, but plenty of people would give it to you because then you've got a prescription and you're involved and all the rest. But I've had multiple early losses. I have PCOS. Could progesterone be the issue? Probably not, because If you have PCOS, then you're probably not ovulating. If you're not ovulating, you're not producing corpus luteum, so your progesterone is going to be low, but it's going to be low because of all the other reasons, not because you can't make progesterone. A functional viable follicle is still a functional viable follicle that's released an egg, even if you have PCOS. So it's about getting through the PCOS rather than progesterone. Is it in tablet or injection form? Currently doing stims and I'm needle phobic, you poor thing. So vaginal or injection is what I would suggest you there. Could it be poor egg quality that causes luteal phase defect, low progesterone? Yeah, it could. That's the bottom line. Why would it be low? Should letrozole increase it? Well, it could be low because the pregnancy is failing. It could be low because you didn't ovulate. It depends on the timing that you're doing it. Letrozole, which is a medication which stimulates ovaries to produce follicles, should get the follicle, but are you going to ovulate? Are you going to take a trigger to get ovulation to happen, which in turn will more likely guarantee that the progesterone will go up. Long term, does it have any ill effects on our body down the line? Thank you, that's a great question. Probably not, don't know. Like, what we don't know is a vast landscape compared to what we do know, which is a small little book. So ask me again in 10 years, in 20 years, in 30 years, in 40 years, when you find out that actually giving progesterone in early pregnancy wasn't such a hot idea after all, that it caused these laws of unintended consequences. We just don't know. To the best of our knowledge, we don't think so. We think we're doing the right thing at the moment in fertility clinics. God knows we're asking. We think we're not increasing cancer rates. We think we're not increasing autism rates. We think we're not increasing problems. But who knows what we'll know? And who knows especially what we'll know about frozen embryo transfers in 40, 50 years' time. So these are unknowns. We're doing the best we can with the best available information. But we always should, I think, be pushing back on give me more intervention. We should, our stance should be to give the minimum that is effective and safe. That's what we should be looking at, not just willy-nilly throwing it. And I know I've said things which are at variance of that already, but I'm still operating within what I would consider to be very safe tolerances. I bled before my pregnancy test after transfer in a different clinic. Could progesterone have been too low? Yeah, I suppose it's possible, but maybe, you see, so the progesterone we give you is there to sustain a viable pregnancy. It's there to maintain the environment. But if the pregnancy hasn't taken, then the progesterone we're giving you is trying to fight back against the tide. Your body wants to bleed. It wants to shed the lining. So we're giving you progesterone to try to stop that from happening. So it's more likely that the bleed happened because the pregnancy failed. Giving more progesterone, you need to give enough progesterone to get the lining to be supportive, and after that, you don't really need to give so much progesterone, you just switched off the whole system. Do you take each individual progesterone level into account, or is it one size fits all? Well, there's probably, what are the side effects of not being prescribed enough progesterone? What are the benefits of progesterone in oil injections for low progesterone levels? If you want to check regularly, like every 48 hours, can you provide this service? I put all those four together because it's all from the same person. One size fits all is a degree of confrontation, that statement. We give more than enough progesterone to make sure that you have enough progesterone in your system, which means we're not that clinic. We're not the clinic that'll check your progesterone every 48 hours and dial it back and up. Progesterone in oil, which is intramuscular progesterone, is something I am incredibly reluctant to use. I used it for a long time. I think it causes, as I said, a huge list of really awful side effects, which are just ugly. It causes sterile abscesses, and I don't perceive that it's any better. There was one interesting study I read a while back which looked at giving people progesterone in oil, checking their progesterone levels, and then if their progesterone levels were low, giving them more progesterone. Really interesting stuff, and it did show, it was a small study, so more study needed, usual crap, but it did show that there was an improvement in live birth outcomes if your progesterone was low and if you gave additional progesterone. Now, there's a clever way around that. Just give the additional progesterone from the jump. Don't wait, just give it. So that's what we're doing by giving it twice a day. The side effects of not being prescribed enough progesterone. Well, I mean, if you're not getting progesterone, you're having a frozen embryo transfer, then the frozen embryo transfer is less likely to work, okay? So that's true, but if you're getting progesterone, you're getting progesterone. How much progesterone is optimal before a frozen transfer? Probably half the amount we give. Probably about a third of the amount we give, to be quite to be quite honest. Or, sorry, probably not optimal, but it's sufficient. Once sufficient equals optimal. And that's something that's a very hard thing for people to internalize and accept, especially when there's so much noise out there about low progesterone. But the optimal and sufficient are the same thing. So long as you're getting enough, you're getting enough. Is there such thing as too much progesterone in the body before frozen transfer? Yeah, probably. I mean, where does it stop? You give 2 injections a day, then you start folding in vaginal progesterone as well, and ultimately you'll probably hit a point where it's too much, but I don't have data on that, and I don't even have a theoretical framework where I can say, oh, that's why it would be a problem or not. What are the benefits after transfer? Our transfer couldn't be done after collection as hormone levels too high. So that's, yeah. So this is what I was talking about earlier. When you're doing IVF, your progesterone, as a result of the stimulation medications, can rise. So we always check it around the time of the trigger, because if it goes up at that stage, that suggests that when we put the embryo into the womb, that it won't be receptive, that you've missed your window of implantation. So under those circumstances, given that freezing embryos is really well tolerated by the embryo and it appears to be safe, we know that maybe there's about a 30% reduction in success rates if the progesterone is high at the time of trigger. If you do a fresh transfer, we know that the thaw survival rate's over 99%. So you're comparing a 30% drop in live birth rates compared to a less than 1% chance of the embryo not surviving the thaw. That's a no-brainer. You should freeze the embryos. So that's why that happened to you. How often should progesterone be checked during treatment and early pregnancy? I don't think it should. I think you should be given progesterone, and then I don't think you need to check it. What are the most common side effects you hear feedback about from women in your clinic? The injections are painful, the pessaries are awful, I'm getting a vaginal discharge, progesterone is horrible, I hate this part of it, I'm getting breast tenderness, I'm getting mood swings, I'm tearful, I'm nauseous, I've joint pain, I've abdominal bloating, everything is dreadful, my skin's gone to crap. That's what we hear, okay? And look, that sounds like one of my heart goes out. And all of this is happening while you're waiting for 12 days to see if you're pregnant after a transfer. It's a nightmare. It's absolutely horrific. Anytime you're taking progesterone probably represents a low in your life. Now, you hope to get some optimism at the end of it, but it's a tough time to get through. So the back half of a fertility cycle after transfer is the worst possible time, and it's the time that we give the medication that causes the worst list of side effects. We are cognizant of that. I'm sorry. Most clinics keep you on it for 10 to 12 weeks for medicated FET, yet therapy stops much earlier. I wouldn't say much earlier, but I can see why. I think we've kind of addressed that. What causes natural progesterone levels to be low? Excellent, we're finally actually starting to get to stuff that we've dealt with. That's because you didn't maybe ovulate. How important is progesterone in early pregnancy? It's absolutely critical, but for the most part, in a natural pregnancy, you're producing it yourself. Can more be prescribed if women has naturally low progesterone reserve? So you don't have a progesterone reserve, okay? You just don't. That's not how it goes. You have a corpus luteum which produces progesterone on a cyclical basis. If you have persistently low progesterone levels in early pregnancy, you can give more progesterone. You probably will be given more progesterone, but that speaks more to the quality and value of the pregnancy than it does your own progesterone levels. Again, a tough circle square. Can staying on progesterone in 12 weeks be harmful? We don't think so. And I think that really at the core of why everybody has just gone, a salute, take it, go, take it. We're just giving it to 12 weeks. And that way, I know it's not most people. We don't have to deal with the cohort of people who have got advice from somebody, oh, I can't believe they took you off the progesterone. I can't believe they did this. In my experience, or I spoke to my friend and my friend had 3 miscarriages and then she was on progesterone and then she didn't have a miscarriage and that's because of the progesterone, which is a story we hear all the time. So the whole field has considered. When I started here, when we put our process in place, I was asked, listen, do we just keep progesterone going to 12 weeks for everybody? And I put my hand on my heart and said, look, let's all be honest. Let's all collectively look through the evidence here and do what the right thing to do here is. And that's genuinely, that's what we're doing, you know? But it's tough. Is staying on it for 12 weeks not safer? Why does therapy not do 12 weeks? See question for details. Nearly there. Why to take it and why as an injection? So I think we've gone through that. Is spotting caused by low progesterone? Spotting is caused by maybe a failing pregnancy, which in turn could be reflected by low progesterone. Is there any harm in being on suppositories after IUI? How do you know if you need them? So we give progesterone support to people on IUI. Here, we probably don't need to. I'll put my hand up and go, look, there's no evidence of benefit in that. None, really. Is there any harm in it? Well, define harm. And that's what we've been talking about, I think. We use it, should we? I think if I stopped it, I think I'll be dealing with more pushback than if I keep it going. So, and I don't think there's any harm in being on them, so I'm as guilty as everybody else. What are the side effects of taking progesterone? I think we've done. In what instances would a pessary be introduced along with the injection? Well, I tend not to be quite honest, because I'm giving the injection twice a day as it is. And again, you're just adding more progesterone to the mix to make the person feel better, not because there's any benefit. Why do different clinics use it for different lengths of time in early pregnancy? Can a drop in progesterone lead to a miscarriage? I think a miscarriage leads to a drop in progesterone. My progesterone was always low. Could it be that implanting never happened because of it? Yeah, maybe, but what was there to implant? So if your progesterone was always low, then you weren't ovulating more than likely, or were missing that window where you were ovulating if you don't have a regular cycle. Day 21 progesterone is meaningless because it goes up 7 days after ovulation. If you've got a 50-day cycle, checking a day 21 progesterone is a complete waste of time because you're still in the first half or the follicular phase of your cycle. Does BMI alter dose of progesterone required? Good question. Probably, which is why we front load at the start. Okay, and we give plenty. What is the ideal blood level of progesterone during 2-week wait? Probably needs to be above 26 nanomoles. Again, that seems to be where the data suggests if you're checking it. If your progesterone is low, would this be why periods are lighter than they used to be? Probably not. The periods become lighter when the lining is thinner. The lining is thinner when you're not producing as much estrogen. You're not producing as much estrogen when the follicle isn't as strong. So it's really more estrogen dependent than progesterone dependent. How long into an IVF pregnancy is it safe to keep taking progesterone? There are people who keep you on progesterone under certain specific circumstances until 36 weeks. We don't treat after 12 weeks. After that, it's a conversation you need to have with your obstetrician. Do you implement protocol for progesterone to be taken to 12 to 14 weeks once pregnant? So, as we say, we will take decisions and give advice up to 12 weeks. After that, we won't. Recent miscarriage, I was on subcutaneous progesterone. Is there anything new to add the next time? Fundamentally, each case is different. I'd like to see how the cycle went. Was it fresh? What was the quality of the embryo? Assume was good. It's a different embryo. That's the fundamental difference between one cycle and the next, between 1 month and the next. Different egg, different embryo. That is the night and day difference in all of this, and that's a hard one to understand, but that's what's much, much, much more important. The new thing that you're adding next time is a different embryo. What week do we need to take up to after FET? So you need it for 2 weeks after, 2 weeks after a pregnancy test, after an FET. After that, need is a strong word, okay? Might as well take it because there's that balance between how much is the pregnancy doing and how much is the corpus luteum doing as it kind of that balance shifts. So you can go for a bit longer. Can I request to prolong the use of progesterone after viability? These are two really good questions, actually. We're finishing up with these two questions. Can I request to prolong the use of progesterone after viability scan? I think that question is at the kernel of everything we're talking about here. It speaks to somebody saying, look, I understand that you don't want to do it. I understand that you're saying there's no evidence for it. However, I'm being told by either another doctor or another healthcare profession or an associated healthcare person, be it your acupuncturist or your reflexologist, or maybe you're an early pregnancy unit, or maybe you're talking to a friend or something, and they said, look, you might as well keep it going, and they undoubtedly quoted you an anecdote to say, this is it. So you've come back, cap in hand, probably a little bit fearful that your doctor or your person will be cross with you. And say, listen, can I just keep it going? I'm just really nervous. This is a terrifying time in my life, and this will make me feel better. Okay? What a tough situation for everybody. Isn't that really, that's just really, really tough. So you're asking your healthcare professional to prescribe a medication that you don't need, that is of no benefit for you, to make you feel better. All right? It's probably not great medicine. You know, I'm not saying no. I'm really happy to have these conversations with people. I don't want these conversations to be confrontational. I don't want these conversations to be to be butting heads with people. But equally, I want there to be trust. And when you're attending for something as fraught and as difficult as fertility treatment, you need to have a measure of trust in the people who are providing that care. And you need to have a measure of trust that they genuinely are on the same page as you. They have your best interests at heart. They just want to get you across the line. And if there is that disconnect between the care that that organisation or that person says they want to provide for you and what you want, then I'll be really honest with you, and this sounds like a false statement, it's probably not it's not a good fit. It's not. It's something where if you feel you have to be the director and agent of your own medical care, that's a problem. That's a problem. You shouldn't have to be. You should be involved, you should be aware, you should be very knowledgeable about it. But what you're doing with treatment, something that's difficult, is you are handing a degree of control over to the healthcare professional who's minding you. You know, and you have to trust them. And if you don't trust them, then there's probably wider issues. That sounds like an awful statement. I don't mean it to be an awful statement. I really don't. Can progesterone delay bleeding in a miscarriage in early pregnancy if the pregnancy is not viable? This is the last question, and the short answer to that is yes. So if you're asking what the harm in giving progesterone is that, and what we will see frequently is people who stop progesterone and then get a miscarriage and a pregnancy loss and go, well, if I hadn't stopped the progesterone, I wouldn't have got, sure, it was the MRI scan that gave me the cancer. You know, of course it wasn't. You know, the pregnancy was failing, the progesterone was supporting a failing pregnancy, so you stopped it and then the bleed happened. And it's really unfortunate timing. It's very hard not to pin it on the progesterone. We deal with this all the time. It's yet another reason to keep it going. But what happens then is you do a scan and then maybe everything's fine, the scan, or then you get told 3 weeks later, I had another scan, it turns out the baby stopped growing at 7 weeks. And I didn't know about it for another 3 or 4 weeks, or 5 weeks, and then I had some spotting or something like that, when finally the body is breaking through the natural barriers that we've put up by giving you medication. So that is one of the downsides, is that we are just holding on to things that are not viable. So listen, guys, in some ways, like, this is much easier because I'm not talking to real people who are giving me flack back. Please come back to Renee specifically with your comments, questions, queries and concerns on all of this. I do think it's something we are looking at constantly. The evidence that we should keep progesterone going in people who, in IVF pregnancies, in fertility pregnancies rather, where there's bleeding and there's been a history of loss until 12 weeks, and that was very recent, that has kind of fired a shot across my bow. So this is a conversation that's very, very live. Hand on my heart, we were having ongoing conversations about how long we push progesterone out to. But it feels reactive to me. And it feels like I'm just getting into bed with something that's not ideal. And it also feels that I'm supporting an ethos that blames women for pregnancy loss and blames their bodies and blames their lack of progesterone, when really that's not at the root cause of it. It's sitting with the embryo. So it is something that's not quite as simple as just trying to appease some people by giving them extra medications that they don't need. But it is something we have under constant review. That's my time. I do hope that was a little bit instructive, a little bit informative. I hope there's some positive stuff that people can take from it. And do mind yourselves. Take care.